Good morning. Today we're going to discuss the global initiatives for chronic obstructive pulmonary disease. In addition, we're going to define the disease process, clinical signs and symptoms, how do you diagnose, all the laboratory data pertinent for the diagnosis, and outpatient as well as inpatient management. So basically, we're going to go over the definition and overview of COPD and the global initiatives, diagnosis assessments, therapeutic options, management of the stable COPD as well as the exacerbation. In addition, how to manage comorbidities and the differential diagnosis of COPD, and even more comparing it to another obstructive pulmonary disease, which is asthma. So, what is COPD? Well, COPD, even though it's preventable because the major risk factor is smoking, is an airflow obstruction. It is caused by, if you remember in pathophysiology, an inflammatory response to inhaled toxins such as cigarette. But many patients have COPD due to alpha 1 antitrypsin deficiency, which is basically an enzyme that provides elastance and compliance to the lung tissue. In addition, patients could develop COPD due to occupational exposure, such as, toxins, asbestos, patients that are exposed to silica, etc. So it's very important that you request the patient data from prior job if they're retired or current work. Symptoms basically is productive cough with dyspnea that develop over the years. The common signs include decreased breath sounds, prolonged expiratory phase on expiration, and wheezing. So it is preventable. It is characterized by persistent airflow limitation and obstruction. It's usually progressive. And as I said, it's basically a chronic inflammatory response to noxious particles that are inhaled. Um, there are also exacerbations and comorbidity that contribute to the severity of the disease. Is the fourth leading cause of death in the United States behind heart disease and cancer and CVA. So it's very important to prevent this disease and to manage exacerbations. So the mechanism underlying COPD, um, basically, again, patient is exposed to inhalation toxins that trigger an inflammatory response in the airway. This could be the small airways producing inflammation, fibrosis, and mucus plugs due to the amount of secretions that they harbor, uh, and also increase airway resistance. The process is thought to be mediated by an increase in protease activity and a decrease in anti-protease activity. So in other words, basically there's an affection of alpha 1 antitrypsin deficiency. Long proteases such as neutrophils elastase, remember that alpha 1 antitrypsin promotes elastance and compliance. So all these metalloproteins break down elastin and connective tissue in the normal process of tissue repair. So there is normally in the lung a balance by antiprotease, such as the alpha 1 antitrypsin, and there's also airway epithelium delivery secretory leukoproteinase inhibitors. So in patients with COPD, this balance is lost. Activated neutrophils and other inflammatory cells release protease as part of the inflammatory process, and the protease activity exceeds the antiprotease activity. So the normal balance that we have between protease and antiprotease activity is lost, and tissue destruction and mucus hypersecretion results. Neutrophils and macrophages activation also leads to accumulation of free radicals, such as hydrogen peroxide and superoxidized anions, which inhibit antiprotease and cause bronchoconstriction. In addition, patients have mucosal edema and mucus hypersecretion. So this neutrophil induced oxidative damage release profibrotic enzymes and reduce level of vascular endothelial growth that contribute to apoptosis, if you remember that in patho. So the inflammation in COPD increases as disease severity increases, and in severe advanced disease, inflammation does not resolve completely despite smoking cessation. Now, you cannot tell the patients that um, even though they quit smoking, the inflammation will proceed, because otherwise they would say, well, what's the point then in decreasing or quitting completely smoking? It is irreversible, but the earlier you quit smoking, the better the progression of the disease. So the less the complications. This chronic inflammation does not seem to respond to corticosteroid, um, even though as part of the management, we should try to decrease inflammation and avoid the progression of the disease. So, but again, in the pathophysiology of the disease per se, even though the patients try to decrease the risk factors or avoid them completely, the inflammation progresses, but corticosteroids will decrease that progression. So at the end, patients would have loss of alveolar attachment and decrease of elastic recoil, limiting airflow and provoking obstruction. As I said, is one of the leading causes of morbidity and is the fourth leading cause of mortality worldwide. Um, the exposure to COPD to risk factors and the aging of the world's population has increased this data. COPD is associated with a significant economic burden because remember there is a high disability. These patients uh, with severe pulmonary disease and having so much decreased forced expiratory volume in 1 second less than 50%, they basically cannot continue working. They are oxygen dependent. They require long-term care facilities for pulmonary rehab, etc. And of course, there is many complications associated with it because now these patients would have pulmonary hypertension associated with this chronic obstructive pulmonary disease and therefore heart failure. What are the risk factors for COPD? Well, it could be genetic, but the leading cause for COPD is tobacco abuse. In addition, patients could have occupational dust or organic or inorganic exposure. Um, so besides cigarette smoking, cooking. So it's very important to know if the patient is a cook. Heating products is an important causative factor in developing countries. Smokers with pre-existing airway reactivity that is defined by increased sensitivity to inhale methacholine, so you could provoke this bronchoconstriction the same way I explained in asthma. Even in the absence of clinical asthma, are at greater risk for developing COPD than are those without. So if the patient is exposed to toxic fumes, this is a major risk factor. Low body weight, childhood respiratory disorders, exposure to passive cigarette smoker as well, air pollution, occupational dust such as mineral dust, cotton dust, inhaled chemicals such as cadmium, that contributes to the risk of COPD, even though are of minor importance than cigarette smoking. Uh, Gender, male, age, elderly patients, respiratory infections, even though it's not a major risk factor, contributes to their exacerbations, socioeconomic status, and even chronic bronchitis. So again, a cigarette smoker is the leading risk factor for COPD, occupational dust as well as chemical toxic inhalers, environmental tobacco smokes such as passive and indoor and outdoor air pollution. So genetic, infections, and socioeconomic status of the patient is highly increased in aging populations. Before we go into diagnosis and assessment key points, let's talk briefly about the comparison of the major two components of COPD. Remember that COPD comprises chronic obstructive bronchitis and emphysema. So, what is chronic bronchitis? Remember that in patho and in pharmacology, we describe that it's characterized by excessive secretion of bronchial mucus that is being present for 3 months or for at least 2 consecutive years. So again, is that chronic bronchitis with airflow obstruction, defined as productive cough most of the days of the week for at least 3 months, total duration in 2 consecutive years. Chronic bronchitis becomes chronic obstructive bronchitis if spirometry, which is the pulmonary function test, evidence of airflow obstruction develops, so the FEV1 is decreased. Chronic asthmatic bronchitis is similar and overlaps the condition characterized by chronic productive cough, wheezing, and partially reversible airflow obstruction. And of course, it occurs predominantly in smoker with a history of asthma. In some cases, the decisions between chronic obstructive bronchitis and chronic asthmatic bronchitis is unclear. So what is emphysema then? Emphysema is an abnormal, permanent enlargement of the alveoli. It's a destruction of lung parenchyma, leading to loss of elastic recoil and loss of alveolar septa. So there is basically retraction, increased tendency for airway collapse, lung hyperinflation, airflow limitation, air trapping, and the air spaces enlarge and they may eventually develop bulla. You need to know the difference between chronic bronchitis and emphysema. If you remember in chronic bronchitis, this patient's onset of symptoms is younger patients, so it's after age 35. And in emphysema, the onset of symptoms is after age of 50, so they're older. In chronic bronchitis, remember the definition is productive cough, so copious sputum production that is purulent, that emphysematous patients do not have this, and if they do, is a very mild sputum. Another major difference in chronic bronchitis, these patients are obese. And emphysematous patients, they're thin, they're wasted, they're cachectic. If you are going to compare the amount of dyspnea, chronic bronchitis patients have mild to moderate dyspnea versus emphysematous patients that have progressive constant dyspnea. Now, if you are going to recall the health assessment, percussion, if you're going to percuss the thorax for patients that have chronic bronchitis, is normal because even though they have copious secretions, there is no consolidation, there is no infiltrate, so there's no reason to have dullness to percussion. So the percussion is normal. And since emphysematous patients have hyperinflation, their percussion is hyperresonant. Now, in the chest x-ray, the chest x-ray for chronic bronchitis patients, since by itself isolated, no included in COPD, of course, isolated patients with chronic bronchitis, the AP diameter is completely normal compared to since there is hyperinflation and emphysema, the AP diameter is increased. So Patients with chronic bronchitis, they tend to be hypercapnic and hypoxemic. That is not affected in emphysematous patients. So, how do you diagnose COPD? So, that should be considered in any patient that has dyspnea, chronic cough with copious sputum production, and a history of the risk factors that we have discussed. So, how do you diagnose not only based on the clinical signs and symptoms, but also through spirometry? So, pulmonary function test or spirometry is required, is mandatory to make the diagnosis. You could assume that the patient has COPD because of the risk factors and the symptoms, but the only test that is definitive to diagnose COPD is the spirometry. So, what will you see in the pulmonary function test? So, basically, what you see is um, a forced expiratory volume in 1 second is decreased less than 70%, or the ratio forced expiratory volume in 1 second versus forced volume capacity or forced vital capacity is less than 0.70, which is the same thing as 70%. So patients suspecting or having COPD should undergo pulmonary function test to confirm airflow limitation. Basically, quantifying severity and reversibility, because after you give bronchodilator therapy, you could repeat the pulmonary function test and compare the FEV1 with a ratio. And if there is more than 12% improvement, then the patient has a chronic obstructive pulmonary disease or any other type of obstructive pulmonary disease such as asthma. But of course, asthmatic patients don't have the same risk factors as COPDers. So FEV1, which is the volume of air forcibly expired during the first second after taking a full breath, is decreased. And the forced vital capacity, which is the total volume of air expired with maximum force, is decreased. So the ratio again is less than 0.70, which is 70% or less. The decline occurs rapidly as the disease progresses. When the FEV1 falls below about 1 liter, patient develops dyspnea with activities of daily living, um, progressive hyperinflation due to incomplete exhalation, to a degree, of course, of obstruction. In addition, what you could do is to look at the flow volume loop, which are simultaneously a spirometric record of airflow and is also going to be affected. So the goal of COPD assessment are to determine the severity of the disease, airflow limitation, and the impact of health status of the patient. Comorbidities occur very frequently. These patients tend to be hospitalized with progressive worsening shortness of breath as well as pneumonias due to the amount of secretions that they harbor in their lung. Again, symptoms: shortness of breath, chronic cough, abundant sputum production, the exposure to the risk factors that we have discussed, including, remember, tobacco abuse, and spirometry is required to establish the diagnosis. So again, can emphasize more that spirometry should be performed before and after though the administration of a short-acting beta agonist, which is the albuterol or levobuterol, and a post-bronchodilator uh, FEV1 slash FEVC less than 70% confirms the presence of airflow limitation, because the patients with asthma tend to improve 12% or more bronchodilator therapy, but this is a reversible um, obstruction. In COPD patients, it doesn't improve the majority of the time. This is the loop for the volumes and capacities. So normally you inspire and there is a plateau here, and then you expire. Okay, and as you expire, you actually measure your forced vital capacity. Normally, the FEV1, so the forced expiratory volume in 1 second, if you are normally taking 8 liters of volume, at least half should be exhaled in the first second. So again, this is the normal loop, which is called the flow volume loop. And this is the loop for patients with obstructive pulmonary disease. As you could see, the inspire volume or the total lung capacity is diminished, as well as the um, pressure for expiration. So if you come back here, the forced expiratory volume compared to the forced vital capacity ratio should be 80%, as we discussed in normal patients and even patients with asthma with mild, intermittent, and continuous. But look at the amount that patients with COPD have. It's normally less than 70%. And of course, it goes lower depending on the stages of the disease. Patients normally should expire half of the amount of volume they inspire in the first second. Look at the amount that the COPDs could expire. It's less than a third. So for the management of COPD, you have to assess the symptoms. You have to assess the degree of limitation using spirometry, risk of exacerbation, as well as comorbidities. So again, what are the main characteristic symptoms for COPD? Even though this is repetitive, is dyspnea, which is progressive, persistent, and is characterized that is worse during exercise. Chronic cough that even though could be unproductive, the majority of the time is productive with abundant sputum production. You could also assess the symptoms by using some questionnaires that are present in research study, which are called the COPD assessment test, the clinical COPD questionnaire, and also the breathlessness scale. Basically, for example, the CAT test is like 8-item measure of health status impairment. Patients are asked if first, how often they get short of breath, during which type of activity, if it's during exercise, during climbing stairs, during regular activities of daily living, and also comorbidities associated with COPD and how many exacerbations they have developed. Okay. And breathlessness measurement is also associated with the same measurements that I described, and all of them predict mortality risk. For example, the breathlessness questionnaire asked the patient, I only get breathlessness during strenuous exercise or while I'm walking, or I have to stop for breath when I'm walking on my own pace, or I have to stop because I have to catch my breath about 100 meters, a few minutes, or I'm too breathless to leave the house and I'm breathless when I'm dressing or undressing. So basically, if you're at this level, you're severe and you're basically disabled. You don't need to know the questionnaires, but it's important to know the classification for GOLD, okay, which is, remember, is the Global Strategies for Diagnosis and Management of COPD. So mild COPD is when they have an FEV1 more or equal than 80% predicted, which is normal, even though remember that by classification, most of the time patients with COPD are less than 70. But GOLD's criteria says that you might have fissures, clinical fissures, um, and you are smoking, you have clinical features of COPD, but you're not at the main classification yet. So you're mild when you're normal, you're moderate when you're less than 80%, but more than 50%. You're severe when you're less than 50% or more than 30%, and you're very severe when you're less than 30%. And all of this is based on pre and post bronchodilator therapy. So if you look, the main definition for COPD, when it's diagnosed, they're already at the moderate level. So how do you assess the risk for exacerbation? So basically use the history of exacerbations and the spirometry. In addition to that, um, there are several types of exacerbation. Patients have type 1 exacerbation, which is severe, type 2 exacerbation, which is moderate, and type 3 exacerbation, which is mild. Basically, it defines the severity of three main symptoms that we discussed, right? The worsening dyspnea, the increase in in sputum purulence, and the sputum volume. So if the patient now says that they are coming to you because they have worsening of shortness of breath, they have done all the bronchodilator therapy. They are using combination disc of either LABA with inhaled corticosteroids, or they're using anticholinergic therapy in conjunction with SABA, and it's not working. They're using their rescue inhaler and it's not working. So my shortness of breath is worse. And I used to walk to the park or bike, and now I cannot even walk. So that means worsening of shortness of breath. That is one of the symptoms. Or I don't have changes in color of the sputum, but I have more quantity. So quantity is another value for that is counted as exacerbation, as well as color. So again, worsening of dyspnea, changes in color of sputum, so that's purulency, and also the volume of the sputum. So type 1, which is severe, have all the three symptoms. Type 2 has two of the three symptoms. So you could have worsening shortness of breath with changes in color, but not in abundancy. And type 1, of course, is going to be mild and include only one of the symptoms. Could be only worsening of sputum production, but I'm not having shortness of breath, or only worsening dyspnea, but my sputum has not increased or changed in color. So in addition to that, patients could have upper respiratory tract infection within the past 5 days. They could have fever without any apparent cause. They could have increased wheezing. They could have increased cough, um, or increased respiratory rate or heart rate. Many of the exacerbations are triggered by infection, either viral or bacterial, or by environmental exposures. All patients who present with symptoms consistent with an acute exacerbation of COPD should undergo chest x-ray, even though, again, is not pertinent for the diagnosis of COPD. You need to evaluate and rule out the possibility of pneumonia or pulmonary edema. Okay, so two or more exacerbation within the last year, or an FEV1 less than 50% predictive. If you really come here, less than 50% predictive is an indicator of high risk because you're severe already. Okay. One or more hospitalizations for COPD exacerbation should also be considered as high risk, and this you need to know. Now, who is at increased risk? Of course, if you have COPD plus cardiovascular diseases, you know that patients with COPD, chronically, the pulmonary pressure increases in the lung. That um, um, regurgitates back pressure goes back to the right ventricle, increasing right ventricular pressure and therefore failure. So these patients tend to have not only valvulopathies but cardiomyopathies as well as right-sided heart failure because they need to use um, uh, not only inhaled corticosteroids but as well as oral or IV corticosteroids during exacerbations. They tend to have osteoporosis because of the amount of secretions that are accumulated. They tend to have recurrent respiratory infections, anxiety, depression because they cannot breathe, because of solomedrol as well or any type of corticosteroids, diabetes. They tend to have bronchiectasias. Bronchiectasis is the permanent dilation of the bronchioles that also harbors a lot of copious purulent sputum, and therefore they're high risk for lung cancer, they're high risk for recurrent pneumonia. So having these comorbidities with COPD increases morbidity and mortality, and of course, rehospitalizations. Okay, so let's compare asthma with COPD since we have discussed already asthma in the classroom. COPD, again, onset is midlife. Asthma, it doesn't really matter. You could be a neonate and have asthma. Symptoms of COPD are slowly progressive and is irreversible. And the symptoms of asthma vary, even though the triggers could be the same, but it varies day by day and is reversible most of the time. Symptoms of asthma, as well as we discussed in class, they're worse at night and early in the morning, and is associated with other atopic conditions such as rhinitis, allergy, eczema, and there's a family history of asthma that is not present in COPD. The major risk factor that they have is a long smoking history. They could have genetic predisposition because due to alpha 1 antitrypsin deficiency it could be passed on to the next generation, and therefore they got that defective gene, and that's the reason why they have COPD. Now, how do you diagnose COPD? Well, the only method of diagnosis is spirometry, but you could do chest x-ray, again, as I said, to rule out possible complications such as pneumonia and pulmonary edema. You could do in the pulmonary function test the lung volumes and diffusing capacity that basically will help you differentiate the levels of severity. You could do ABG to basically evaluate the oxygen saturation. Remember that these patients, the oxygen should be only administered by nasal cannula or face mask to improve the partial pressure oxygenation or PaO2 to 60% or the oxygen saturation to 90 or 92. So do not overtreat because the increase of oxygen tension could precipitate hypercapnia. Remember that. Okay, so the PaO2 to more than 60% and the saturation up to 90%. That would be enough for them. Now, of course, unless they are on a critical exacerbation and the oxygen therapy um, does not correct the hypoxemia, then you should consider either initiate BiPAP therapy or, of course, endotracheal intubation. But the patient must be critical. Alpha 1 antitrypsin deficiency screening that mainly is performed in Caucasian descendants under 45 years of age and when the patients have a strong family history of COPD. You could also do a 6 minutes walk. This is basically to measure the impairment of, you know, capacity of the patient to breathe properly. So basically, what you do is you um, take the patient to the hallway and walk the patient for 6 minutes and or increment exercise and do an ABG. We also do this in inpatient facilities when the patients um, by ABG baseline they have hypoxemia and we are sure that the patient require oxygenation upon discharge. We discontinue the oxygen. We order 6 minute walk testing to prove basically to the insurance companies, of course, that the patient requires oxygenation and therefore it is approved. But without that legality, basically what measure is impairment. So you assess the patient and tell them to walk at their normal pace, and you could even increment the exercise activity to basically predict the prognosis of the patient and the need for oxygenation. Okay. In addition, you could do a composite score, which basically entails several variables. Is the pulmonary function test, the 6 minute walk testing, weight loss reduction, um, and also the ABG, as I said. Okay. Very important, as I said, smoking cessation is has to be approached in every single hospitalization, in every single encounter, even outpatient. You should encourage to quit smoking constantly. Okay, offer pharmacotherapy such as nicotine replacement through patches, through lozenges, through everywhere. But you should approach this in every single visit. So, what would be the best pharmacological therapy for them? The guideline includes treatment with short-acting beta-adrenergic receptor agonists, which is the SABA, and the short-acting anticholinergic agents. Overall, because of the side effects, even though anticholinergic, which are the anti-muscarinic, produced tachycardia and also produce dry mouth, and they're also at risk for tardive dyskinesia. When you, by research, of course, when you outweigh the risk of side effects with the side effects of beta adrenergic agonist, anticholinergic are favorable. So anticholinergic therapy were decided to be the first option for patients with COPD. So you should not omit as bronchodilator therapy the anticholinergic therapy. Okay, so you used bronchodilator therapy, you used your SABA, which is there, and the anticholinergic, and you could also use corticosteroid therapy, antibiotic therapy in every exacerbation. Basically, what you're trying to reduce is not only the symptoms, but the frequency and severity of the exacerbations, and of course, improve the health and the exercise tolerance of the patient. Influenza and pneumococci vaccination should be offered by guideline. Counseling by healthcare professionals to uh, increase the quit rate and also um, talk to them about the urge of um, quitting. Have you ever thought about quitting? And again, offer nicotine replacement therapy such as nicotine gum, nasal spray, patches, tablets, lozenges. Again, as you could see, it's very important for them to eliminate the main risk factor. So ask systematically to tobacco abusers in every single visit, advise them to quit, assess their willingness to quit, and assist them in quitting, and also schedule follow-up contacts with them. Another slide from them that is basically you should do a comprehensive evaluation of quitting. You could even offer them free sites in the internet and telephone numbers where they could call, uh, that it won't cost a penny for them to quit. Emphasize always that this is a primary prevention. In addition, reduce the indoor air pollution, um, cooking and heating in poor ventilating dwellings. Advise to monitor public announcers for air quality, because that's the major risk factor after smoking. So again, what will you prescribed? Again, outpatient management, discontinuation of smoking, avoid of irritants and allergen. In addition to that, since they have a lot of secretions, you would like to provide aggressive pulmonary toiletry, um, postural drainage to be able to clear all the secretions. Use low flow oxygen, minimal like 1 to 2 liters nasal cannula, or if you're using venti mask, low flow as well, 24 to 28%, no more than that, because remember you could exacerbate hypercapnia or precipitate hypercapnia. In addition, again, bronchodilator therapy, which is your beta agonist, and those are the albuterol and levobuterol. So you could give, for example, 2.5 to 5 milligrams every 4 to 6 hours. Um, Anticholinergic agents, short or long acting. You could give as short acting ipatropine bromide, which is atropine, 0.5 milligrams every 4 to 6 hours. You could also do the combination disc. You could use methyl santings, even though it's not the best recommendation by guideline, even though this is coming from them, it should be at the bottom. But corticosteroids, you could use oral or IV. If you use oral medication, it would be prednisone, 30 to 60 milligrams every day for like 5 to 7 days. And if it's a longer course, remember to taper it down. Methylprednisolone, which is solumedrol, you could give again a bolus of 125, and then go down to 60 milligrams um, every 6 hours for 4 days, and then continue tapering down to 40, then to 20, etc. You could also do combination, of course, inhaled corticosteroid, which is even superior than oral. Combination of long-acting and beta agonist. Um, in addition to that, antibiotic. And the antibiotic, basically what you're trying to cover here is the streptococci pneumonia, the Moraxella catarrhalis, and the Haemophilus influenza, which, if you remember, are exactly the same microorganism for pneumonia. Now, in patients with more severe disease, you must remember gram-negative bacteria, which is Pseudomonas. In the past, and was still used, but in the past, the first line will be amoxicillin or um, Bactrim, which is trimethoprim, soap of metolsazole. You could have used tetracycline, clarithromycin, azithromycin, ciprofloxacin, or levofloxacin, etc. Now, because of the concern of antibiotic resistance, broad spectrum antibiotic are nowadays better. So now we encourage to use by guideline either clarithromycin, azithromycin, levofloxacin, or moxifloxacin for 5 to 10 days. But in case you get a question about COPD antibiotic use, in boards continues to appear ampicillin or amoxicillin 4 times daily. Or another choice would be doxycycline or Bactrim DS. But again, in clinical practice, more and more we use clarithromycin, azithromycin, levofloxacin, or moxifloxacin for 5 to 7 days. Phosphodiesterase 4 inhibitors, those are your um, medications for pulmonary hypertension. Okay, so you could use their Revatio, for example, is one. So bronchodilator therapies are central for symptomatic management of COPD. And remember, there is your beta 2 agonist, which is the SABA, and the anticholinergics. Even though Theophylline is a bronchodilator therapy, orally and IV, we encourage more by guideline the beta 2 agonist and anticholinergic first before you even introduce Theophylline because of the side effects and the short half-life that you need to constantly monitor um, levels. Remember, the levels are 10 to 20, otherwise you become toxic. In addition, you could use long-acting inhaled bronchodilators that are convenient and effective as well. Uh, but again, it's a stepwise approach, the same as asthma. You use your SABA, which are your bronchodilator therapy, and there, remember in asthma, you only had the choice of beta 2 agonists. Even though in clinical practice we use atropine in asthma, in the stepwise approach for asthma, anticholinergic therapy is not included. So atropine is not included. It is included in GOLD for COPD. So the first step would be your SABA, including SABA for beta 2 agonist, albuterol, levobuterol, and SABA for, or short acting for anticholinergic, which is your Atrovent. Okay, if it doesn't work, then you could do the LABA. That reduces exacerbation and also relates hospitalization. You also could combine the bronchodilator therapy to LABA and also to inhale corticosteroids to decrease the mortality as well and hospital recurrency. Again, as asthma, you could also introduce the inhaled corticosteroids that improve the symptoms and the pulmonary function test. Inhaled corticosteroids are associated with increased risk of pneumonia, but it is part of the stepwise approach. So this is an overuse. Remember that you become immunocompromised, so even though it's inhaled, there is a systemic absorption. So when you maintain patients with COPD with high levels of inhaled corticosteroids, they're at risk for immunosuppressive disorders, therefore pneumonia. Okay? But if you withdraw them quickly or suddenly from corticosteroid therapy, they could exacerbate. So you need to maintain the minimal level that they require to be stable. So try to escalate, and as soon as they become better, the same as asthma, for 3 months, try to de escalate because maintaining them at a high level of inhaled corticosteroids as well as oral, they become immunocompromised and they're at risk for infection, not only pneumonia, but any infection. Now, don't withdraw them quickly because they could exacerbate and that increases the risk for hospitalization. Okay, LABA combined with inhaled corticosteroids is even more effective than LABA alone. Remember that LABA alone is not encouraged because of the high risk of cardiac mortalities. No, in addition, you could combine beta agonists with inhaled corticosteroids as well as you could combine them with anticholinergic therapy. Now, chronic treatment with systemic corticosteroids should be avoided, but also you have to look at the benefit risk ratio because even though you know that steroids have a lot of side effects, right? They could maintain these patients stable mostly patients that have severe COPD, and they could be maintained or kept away from hospital. So in patients with severe and very severe COPD and a history of exacerbation of chronic bronchitis, you could also use phosphodiesterase inhibitor, which are your immunomodulators, are the ones that also decrease pulmonary pressure. So you have the froflumelast, the same as asthma. It's the last step, okay, and also reduces exacerbation along with corticosteroids. Theophylline is less effective. Remember that even though it is listed as the one of the choices for bronchodilator therapy, has a lot of complications, so it's not recommended as first line. Modest bronchodilator effect, and it has modest bronchodilator effect, but remember that produces a lot of side effect. And even though it reduces exacerbation and improved bronchodilator function in the pulmonary function test, um, there's high risk for toxicity. So you could add theophylline to LABA, but remember theophylline could produce tachyarrhythmias, and LABA itself, such as salmeterol, could also produce cardiac complications. So you have to be very careful. So yes, there is an indication, there is a beauty to it, but we use the theophylline when there is no choice. Influenza vaccination, remember that reduces the illness, superimposed pneumonias and superimposed viral syndromes. So every single patient that has COPD should be vaccinated with influenza after 50 years old, and with pneumococci vaccination after 65 years of age or more, and even younger if the FEV1 is less than 40%, which is very severe. Antibiotic, we already discussed, is basically used for infection exacerbation and other bacterial infections, but don't overuse it. Alpha 1 antitrypsin augmentation therapy is not recommended for patients with COPD that do not test positive for this genetic deficiency. In addition, you should add mucolytic therapy, because remember they have as an underline abundant sputum production. Not recommended antitussive therapy because remember these patients need to expectorate. In addition, you could use vasodilator therapy such as nitric oxide, but is only indicated in acute exacerbation, not in patients that are stable. Exercise training, these patients should undergo um, pulmonary rehab to basically improve the exercise tolerance and decrease the dyspnea and the fatigue that they're constantly complaining. Insurance approved this for 6 weeks and even longer if it's necessary and if it's reapplied. But you could also encourage this training at home. We tell the patients to go to the supermarket and try to push the shopping cart, because by pushing improve the strength of the accessory muscles, scalene, sternocleidomastoid, as well as intercostus and diaphragm. Oxygen therapy, remember that um, it is necessary in patients that have severe hypoxemia, but do not overuse it because you should not overcorrect the hypoxia that they have because it could provoke hypercapnia. Now, what happens when patients come in and they are complaining of shortness of breath, productive sputum, sometimes even fever, You put the patient on oxygenation, the PaO2 is less than 60%, the saturation is less than 90%, they're hyperventilating, they are basically in respiratory alkalosis. You should initiate bypass therapy and reassess periodically. And if the patient goes into respiratory failure, of course, you should intubate the patient. So combination of non-invasive ventilatory support, which is the BiPAP, with long-term oxygen therapy may be enough for the hypercapnia. In addition, other measures that it could be done, long volume reduction therapy. Um, this basically is for patients that have bullous emphysema, um, consists on resecting non-functioning ephematous area. The procedure improves lung function, exercise tolerance, and as well as quality of life. Um, it's basically predominantly in the upper lung emphysema parenchyma. Um, Mortality is increased in the first 90 days after volume reduction therapy, but if the patient survives, is higher than 5 years. In addition, you could do lung transplantation. So if you see that the lung capacity is severely reduced, um, you could put the patient in a transplant list. Perioperative complications tend to be lower with single lung transplantation. Candidates for transplantation are patients that are less than 65 years of age with an FEV1 of less than 25% predicted. So you should see that actually they're lower than very severe classification, as well as with severe pulmonary hypertension. Transplantation will improve quality of life um, 5 years after the transplant. But remember, they are very high risk for opportunistic infections as well. And in addition, before we finish, palliative care or end of life care. So you need to communicate to the family members and the patient itself that you have done everything possible to hasten the disease process, and now the pulmonary function test is less than 50%, and they're declining, so they should consider while they're waiting for transplant list if the one of the lungs has the capacity to withstand the surgery, because you need to have enough volume in the remaining lung to support the surgery. So let's talk about exacerbations before we finish. Um, so we set the criteria already. So worsening dyspnea, increased sputum purulence, and increasing sputum volume. In addition, patients could have recurrent respiratory infections, fever, with no cause apparent. So there's no pneumonia, there's no UTI, there's no any infectious process associated with it. So you do the initial evaluation, you look at the laboratory data that patient could have increased WBC, increased PaCO2, and also a compensatory metabolic alkalosis. Um, you look at the basic metabolic panel to see if there is any dehydration process. Chest radiographic, again, to rule out pneumonia and pulmonary edema. You do an ABG, and if you believe that the patient has the clinical data pertinent to COPD exacerbation, you should put the patient on oxygen by nasal cannula or face mask. Remember, 1 to 2 liters nasal cannula and 24 to 28% venti mask, unless, of course, there is more hypoxemia that you should put the patient on BiPAP or intubate the patient. We discussed already bronchodilator therapy, um, corticosteroids, antibiotic, and if it's necessary, of course, proceed to ventilators. So most patients require oxygen supplementation, even though um, they do not need it chronically because they live sometimes with hypercapnia. I have received patients with CO2 of 70 and 80, and they're talking to you when they should be dead or intubated. This worsening has traditionally been thought to resolve from an attenuation of the hypoxic respiratory drive. There is a VQ mismatch, probably that is affecting the value of the PCO2. Um, Non-invasive ventilatory support, such as bilevel airway pressure ventilator by face mask, is an alternative to full mechanical ventilation. Non-invasive ventilation appears to decrease the need for intubation, reduce hospital stay, and reduce mortality in patients with severe exacerbation, which you know already the definition. Um, However, it may be indicated for patients with less severe exacerbation when the ABG, of course, has um, severe respiratory acidosis. Otherwise, of course, you have to choose mechanical ventilation. So the key points again is the identification and reduction of exposure to risk factors, individualized assessment of symptoms and airflow limitation, rehab, and of course pharmacological therapy to reduce the symptoms as we discussed. How do we do this? By again, go by a stepwise approach. You start with the SABA, which is your albuterol and levobuterol. Um, you could add the short-acting anticholinergic, which is again is more beneficial. And if the patient doesn't get better, then you do exactly the same as asthma. You add the low dose inhaled corticosteroid, then you add the LABA or increase the dose of the inhaled corticosteroids to moderate. And remember the alternative of treatment that you have exactly the same, as well as you could end up in the last step with the maximum dose of inhaled corticosteroids plus LABA, plus anticholinergic, plus theophylline, plus oral corticosteroid, even with antibiotic treatment. Remember that phosphodiesterase 4 inhibitors, such as your immunomodulators, as well as your medications to decrease pulmonary hypertension, are described in the last stage when the FEV1 is less than 50%. So relieve the symptoms, improve exercise tolerance, improve health status, prevent disease by quitting smoking and inhale toxins, prevent exacerbation, and therefore you will decrease mortality. So how do you do that? Smoking cessation, reduce indoor pollution, reduce occupational exposure, flu vaccination. What is exacerbation again? Characterized by worsening of the patient respiratory symptom beyond the day by day variation. So I have increased or worsening shortness of breath. I have changes in status of quality of the sputum. It's more green, it's yellowish, it's more abundant. Okay, most common causes are viral upper respiratory tract infection. Diagnosis require exclusively on clinical presentation, so that's the reason why, even though the PFT is necessary, you never do pulmonary function tests during exacerbation. You do pulmonary function tests when the patients are stable. So therefore, the exacerbations are based on clinical symptoms. Okay? So what do you give again? In the exacerbations, your short-acting beta agonist, with or without anticholinergic, even though, remember, this is very good for them, okay, should be added. Those are the preferred step. Then, again, the same as asthma, you could add the inhaled corticosteroid, You could increase the dosages. You could add the systemic corticosteroid orally or IV. You could add the antibiotic treatment. For your exam, the antibiotic treatments of choice again are ampicillin or amoxicillin, followed by your levaquin. That's the reason why we give levaquin for patients that have pneumonia with comorbidities as an outpatient, as a community acquired greater than 65. The same way we give levaquin for patients that have COPD exacerbation because it's the second line and it's useful. Is actually nowadays more used than ampicillin and amoxicillin. But for your exam again, ampicillin or amoxicillin, second line, levaquin, or doxycycline or Bactrim. Even though, of course, we use azithromycin as well in combination with your third generation cephalosporins. Okay. So consequences of COPD exacerbation, of course, it has a negative impact in quality of life, on lung function, on economic cost, and mortality as well. So what do you do in exacerbations? The same way you do in any type of asthma exacerbation or for diagnosis. In the hospital, you do an ABG, right? So the patients should have, if they're exacerbated, the PaO2 less than 80 and the PaCO2 more than 60% to indicate respiratory failure. So if they have a PaO2 less than 80 and the PaO2 more than 60, they are in respiratory failure. Chest x-ray to basically rule out all the disease processes as pneumonia and pulmonary edema. EKG is just to make sure there is no coexisting cardiac problems. CVC. What will you see on the CVC? Well, you could see polycythemia. These patients tend to have a very high hemoglobin, and this is because of the compensation of hemoglobin to be able to carry the molecule of oxygen. Uh, Anemia could be present even though it's not as common as polycythemia, or even bleeding because they tend to have thrombocytopenia. Purulent sputum, so collect the sputum and culture it. Electrolyte imbalances, they tend to have hyponatremia, diabetes, poor nutrition, and of course, don't forget the pulmonary function test, even though the pulmonary function test, this is the question for you, is not recommended during an exacerbation. You're not going to do a spirometry or full pulmonary function test to a patient that has status asthmaticus or a patient that has an acute exacerbation of COPD because they can't catch their breath. Oxygen, remember low flow, bronchodilator therapy, and systemic corticosteroids as I already explained. Okay? The antibiotic is basically to decrease the three cardinal symptoms, and also remember non-invasive ventilatory support, or of course if the patient is in respiratory failure, intubation. So non-invasive ventilatory support, it will improve the hypercapnia and the respiratory acidosis. It will decrease the dyspnea and the respiratory rate, and of course decreases the length of hospital stay, therefore decreasing mortality and the need for intubation. So what are the indications? This you need to know for your exam. What are the indications for hospital admission? Well, if the patient has marked increase in intensity of symptoms, you should admit. Severe underlying COPD, so if the patient has a pulmonary function test baseline less than 50% and now has the signs and symptoms of exacerbation, you should admit. Onset of new physical signs, failure to respond to initial medical management, presence of serious comorbidities such as heart failure, pulmonary hypertension, frequent exacerbations, patient was recently hospitalized, elderly patients, and insufficient home support. So what are the comorbidities that they have? Again, heart diseases, heart failure. They tend to have atrial fib because remember, there's hypertension, pulmonary, that could trigger an extra foci of um, of electricity. So normally you know that the initial input of the actual potential comes from this SA node. So they could create an extra foci and produce atrial fibrillation. In addition to that, to all the electrolyte imbalances that they tend to have and the dehydration. Hypertension is another comorbidity. So if you're going to put these patients because of hypertension in a beta blocker, try to select a cardioselective beta blocker because otherwise you could provoke more heart failure and more tachycardia and more bronchoconstriction. I'm sorry, more bradycardia and more bronchoconstriction. Osteoporosis, remember the osteoporosis because they tend to be on long-term steroid, either inhaled or orally. Frequent death due to lung cancer, serious infection, and even metabolic syndrome because remember they tend to be obese, the chronic bronchitis patients, chubby, with the use of steroids and the stress of the actual disease process, diabetes. So what is asthma? We discussed it in class already. And even though COPD is preventable and treatable, it's persistent, is irreversible compared to asthma. Okay, even though sometimes asthma and COPD they tend to overlap in the same patient. So the age of onset in asthma we discussed it could occur at any age. In COPD greater than 40, and when they coexist is also an elderly person. I mean, no elderly, but old adult. Let me defend myself. Um, Respiratory symptoms in asthma, remember that varies day to day, and it tends to be worse in at night and upon awakening, and also the exposure to allergens. In COPD, is continuous and worse with exercise, and when they coexist, also have the same pattern as COPD. The lung function, remember that since it's reversible with bronchodilator therapy, you already went through the classification with me, the mild, intermittent, and persistent, and moderate and severe, and how the pulmonary function tests vary. In COPD, the AFib1 may improve post bronchodilator therapy in the mild stages, but after moderate and severe, it persists. Okay, and again, has the same variability. And the lung function, again, for asthma could be normal, but in COPD, there's a persistent airflow limitation. Past medical history in asthma, they tend to have any type of atopia. In COPD, basically, you have to look at the alpha 1 antitrypsin deficiency in the family, the same as here. Time course improves spontaneously after bronchodilator therapy, and in COPD is slowly and progressive. The chest X-ray for asthma is completely normal, and the COPD it tends to have hyperinflation and flattening of the diaphragm and increased AP diameter. But remember, if you're going to separate chronic bronchitis from emphysema, the chest X-ray in chronic bronchitis, the AP diameter is normal, and the chest X-ray in emphysema, the AP diameter is increased. The exacerbations in asthma occur if you are exposed to the allergen and is reduced by treatment. In COPD, and the combination is also reduced by treatment, but um, is associated with a lot of comorbidities that asthma doesn't tend to have. So again, the same features that we have discussed, repetitive. In arterial blood gases, if you're going to go and look at the pulmonary function test, the diffusion capacity of CO2, I'm sorry, of the carbon monoxide, is normal between exacerbation in asthma and is severely um, abnormal in patients that have severe COPD, or um, could be mildly reduced in patients that have mild COPD. There is the airway hyperresponsiveness that distinguish them both because both, if they are exposed to allergen, is a trigger for it. Normal CT for asthma. And of course, you know that there is the bronchial thickening and pulmonary hypertension and bullous in COPD. Um, Let me see what else. You have eosinophilia in asthma, not really present in COPD. And the sputum for asthma tends to be scant and light yellowish and yellow and greenish sputum purulent in COPD. This basically is the end of this presentation, and we will discuss in respiratory failure how do you manage the BiPAP as well as the intubation in the patient not only that has COPD but has any disease process that leads to respiratory failure and ARDS. Thank you very much.